Yeah, thank you very much, and good morning, everyone. Thank you, Professor Abron, for giving us the French perspective of the program. We have a very interesting program ahead of us. It's very packed, so I would really like just to jump into it with the clinical indications and the clinical experience of international programs. So it's my pleasure to welcome Professor Piero Fossati, head of the Carbon Ion program at MedAustron in Wiener Neustadt.
Thank you very much, Mr. Chairman, and thanks for the kind invitation. I'm very happy to be here. Yesterday, we couldn't see any horse race, but we tasted some oysters, so that was a very, very nice start to enjoy Normandy. So MedAustron is the only particle facility in Austria and has had a very long history. In the beginning, they wanted to build. Is there a laser pointer? Yes, yeah. In the beginning, they wanted to build a neutron facility just for research, and that was called the Ostron project, and that was in the 80s. And then eventually, the decision was to have it for a more medical facility to treat patients, and then from fast neutrons, which really had some major issues and were not really investigated in depth, but are rather abandoned by the field of oncology, it switched to heavy ions and protons, and so it became MedAustron, which is still based on the same European design dating back to the proton ion medical machine study from CERN. So if you want, it's the same design as the facility in CNAO, and well, the German are slightly different, but is in a way always the same synchrotron. And this long history shows that from the first idea, let's say 2000, to the first patients, it was a long time. First patient was treated with proton in 2016, and then with carbon in 2019, and there was some pressure to start as soon as possible, so all the doctors working there would have preferred to have a full commissioned product and then start treating patients, but we started treating patients and then were forced to do commissioning in parallel. So finally, we had all the room with all the particles in operation a little bit later than that. So all the rooms, what does it mean? There is sources that can produce proton and carbon and helium, and now we are discussing to add oxygen in the next couple of years. And of course a synchrotron, and one experimental room, one room that has a horizontal and vertical beamline, one room that has only a horizontal beamline, and one proton gantry. Positioning is done with this device which has a X-ray ring mounted on the couch, and this now the same they are using in Boston. So this was originally manufactured by an Austrian firma, and again, in one room we treat carbon with only horizontal beam, in one room we treat carbon with horizontal and vertical, in one room we treat only protons. These two rooms have carbon and protons. One room is only protons with a gantry, and one room is dedicated for research. The treatment is performed in Austria. There are about 80% to 85% of Austrian patients and 15 to 20% of international patients. And most of the patients are included in a registry. So right now we have 1,600 patients included in the registry in order to be able to evaluate this data in the future. But there are also specific trials, active clinical studies, either single center like our advanced pancreas cancer or multicentric like the SACRO study. And the system in Austria is like this. We don't have a list of indication like, for example, in Italy. We don't have indication based on dosimetry like in the Netherlands. We have indication based on an external tumor board. So each patient must be discussed in an external institution. They must say, for this case, we recommend particle therapy because it's the best possible treatment. And then with that, for each single patient, we have to apply to the insurance. In Austria, the insurance is called the Krankenkasse. So it's not a national system like in Austria, but it is not a private insurance. It's a social insurance that every citizen has. And they have to authorize individually each patient. When I moved to Austria, I thought this was a nightmare and would never work. Well, it works quite well. The authorization normally is given in 2 days. and the acceptance rate of our patient is 98.5%. So it's very, very rarely that they decline a patient, because people that have to say, okay, pay the bigger amount of money, they have the support of an external tumor board. So it works very well to treat patient, but it doesn't work very well in terms of changing and expanding the indication. Now we have additional evidence coming, for example, from the US, and they have shown this is good for, let's say, hepatocellular carcinoma. But this is new for all the people used to put the red stamp on, yes, I authorize, so they read hepatocellular carcinoma, they go crazy, I have never approved this. So it is a very good system, but it's not very flexible, let's say. What are the patients we have treated? We have treated so far 2,600 patients, and all in all, we are treating mostly central nervous system. This is, if you want, an Austrian particular things. We treat a lot of very complex meningioma. This was in the beginning something that said, well, you don't need particle therapy for meningioma, but we are really getting the very, very complex recurrent skull base with complex shape, high-grade meningioma. So meningioma is a very large part of our activity. Then, of course, head and neck, because of the well-known advantage. Now MedAustron is the biggest pediatric center in Austria. We treat most pediatric patients. We started with patients requiring high dose, but then it became sort of evident for all the people that we were not doing a bad work. So we are treating even patients requiring a low dose. We are treating neuroblastoma, we are treating Wilms tumor. They say even if it is a low dose, it's still better for the child to get proton than. So they even discussed that every resident in Austria must have a little bit of a time at MedAustron, otherwise they will see no pediatric treatment. And then we have a big ray radiation program and sarcoma. This is all the patients. Now, very quickly about protons. Protons is about 2/3 of the patients we have treated. Well, carbon started later. In protons, it is everything as you would expect, and prostate is an almost negligible slice of the pie. But carbon has a slightly different mix. So in carbon, our three main indications at the moment is head and neck, and this, of course, is non-squamocellular. So squamocellular and also non-squamocellular post-op we treat with protons, but non-squamocellular salivary gland, mucosal melanoma, we have a very active program from mucosal melanoma, sarcoma in the head and neck, and also paranasal sinuses. But with bulky disease, we treat with carbon. Sarcoma is another big part of carbon, no surprise there. Inoperable sarcoma, chondrosarcoma, osteosarcoma, chordoma, we treat with carbon. This is the biggest slice, re-irradiation. Now, re-irradiation, as you all know, is a very, very complex and heterogeneous thing, and this is the easiest thing for colleagues to refer. They just have a problem and they get rid of the problem. And re-irradiation, finally, we are now trying to analyze our data and make a step forward, because so far we were following sometimes the German approach, sometimes the Japanese approach, and we really need, we are now analyzing this data. I will briefly tell you about our strategy for head and neck, just to give you the philosophy in MedAustron. We want to use carbon when there is macroscopic disease. We never use carbon as adjuvant treatment. For adjuvant treatment, we always use protons. That there's really no justification in using carbon for adjuvant treatment. We want to use carbon when we are not happy about the local control with standard low LET. So if we have good results published with radiochemotherapy, let's say squamous head and neck cancer, then the main issue would be reduced toxicity, use protons combined with chemo. But there are a number of tumors in which local control is not really satisfactory. So if you have a big, bulky disease and you think you are not going to control that, we are not even dreaming of using carbon for lymphoma. But if we have an osteosarcoma that cannot be resected, so you need local control, you cannot achieve local control, and then this is for us the niche for carbon. So inoperable sarcoma, non-squamous cellular head and neck cancer. We are trying to get recurrent rectal cancer. This is a little bit frustrating because we have this excellent data coming mostly from Japan. There is here Dr. Yamada. He is the one that really taught me that you have to treat these patients because you can do a very good job with them. The problem is you talk to your colleagues and they just send you the standard recurrent, which is an anastomotic recurrence. No, it's not what I can treat. I can treat a pelvic wall recurrence, I can treat a presacral recurrence, which must be separated from the rectum. Otherwise, I cannot give this very, very high dose and achieve excellent surgical eye control. This doesn't sound too difficult, but it is too difficult to communicate to the colleagues. You go there, you make your presentation, show the case, this I want, this I don't want, I'm not able to treat this, but this patient that has no other option, then I can give a curative option. No, I always get referral of anastomotic recurrence. That's a little bit frustrating. This is right now the most controversial but also very interesting topic for us. We are treating high-risk prostate cancer, again following the excellent results reported by Japan, and it is not perfectly clear if we will ever manage to produce evidence convincing for Europe. We are not trying to treat low-grade or intermediate grade. We are trying to treat high-grade prostate cancer, and right now it is really difficult to get reimbursement for these patients, and then we would like to have a sort of wider initiative in Europe to show somehow that the advantage reported by the Japanese centers may be a real advantage and then convincing enough for this patient to get carbon. I was telling you I wanted to give you just a little bit the philosophy of MedAustron approach, and for this I just focus on salivary gland. We know that salivary gland tumor can be treated very well, but there is a subset in which the results of conventional therapy are very bad. So adenoid cystic carcinoma with skull base infiltration is a disease with a horrible prognosis. You cannot put all the salivary gland together. You have to consider the patient that comes to us, and this is most of the time skull base infiltration. Skull base infiltration is really a very bad prognostic factor, and these are results reported by Memorial, and if you give radiation or surgery or chemo, basically it's very, very hard to control any of these patients. So for these patients, we know that carbon ion is a very good option, and there is a German approach and there is a Japanese approach. So they are slightly different. The Japanese approach is treat with 16 fraction, high dose per fraction, everything with carbon, and don't do the elective node irradiation. And the German approach is treat the elective node irradiation with low LET, with conventional fractionation, and then boost with carbon ion. And we are trying to really, in a way, get the best of both worlds. So if you see a bulky adenoid cystic carcinoma with skull-base infiltration originating from the maxillary sinus, then we say, well, we trust the Japanese. We don't need elective node irradiation there. We do 16 fraction Japanese style. If we see an adenoid cystic carcinoma that has undergone a wonderful resection with a big flap, and then the surgeon tells you it is an R0 resection, and then you look at the image and say, yes, but there was an enlarged cavernous sinus even before surgery. So he didn't try to address the skull base. This happens basically every other week. Then we do proton 50 grade to the big postoperative bed, and we just boost the carbon. We are not treating the Japanese schedule with Japanese nominal dose, but we are trying to convert, taking into account the difference of the RB model. This was a long work, and is now more or less becoming accepted by most colleagues. And we have, at the moment, a double set of the nominal local effect model constraints and of the original MKM constraints, and we are trying to always look at both RB models. So we went from conversion of tables to checking the RB weighted dose distribution of the nominal LEM and of the recomputed MKM, and they must both look nice. But this, we believe, is not enough, and there are patients in which we are not happy with the Heidelberg approach and not happy with the NIRS approach. For example, this is a case of very bulky base of tongue adenoid cystic carcinoma. So we need to treat the nodes, but we need to give more carbon to this bulky disease, and for this we have devised this, which is a little bit of a mix. So we give part of the initial dose to the large volume, including the nodes with protons and part with carbon. So the German approach is roughly 2/3 protons, 1/3 carbon. For this group of patients in which we have both bulky disease and need of extensive volume, we try to do 2/3 with carbon and 1/3 with protons. So it's a little bit of a mix between Japan and Germany. Of course, in the future, we would like to be able, for these tumors that are just a category of many other, to do, Jean-Louis was mentioning Hermann Zuid. Well, Hermann Zuid was already saying carbon for the GTV and protons for the CTV, and this is something that we hope in the future to be able to do. Having said that, I will skip the last 2 slides because anyway I have another talk and then they will be dealt in the next talk. Thank you so much.
Thank you so much, Piero, for this overview of the MedAustron facility. Is there one question you would like to ask to Piero?
Piero, why no mention on ocular treatments?
Just because of time, we have started. We have started with eye melanoma this year, and right now. We are the second facility after now that is treating eye melanoma without a dedicated beam line, but with the normal beam line and then the dedicated apertures and devices. But honestly, yeah, Mario, it was the main mover of the CNAO eye program, and now there is a MedAustron eye program. Yes, thank you for mentioning that.
Is it carbon or protons?
No, protons.
Thanks, Piero.
Mario, me too. I don't cover ocular.
So now it's my pleasure to introduce Professor Ester Orlandi, who is the clinical director of the CNAO Center, the National Center for Oncological Hadrontherapy in Pavia, in Italy. She will give an overview of our center in Pavia.
Thank you, Barbara, for the introduction, and thank you to the scientific committee for inviting me. And so let's start with a handful of clinical data. We have treated since the beginning, so from 2011 and 2024, more than 5,500 patients, half with carbon ion and the other half about with protons. You can see that in our, Okay, so in our experience, about 30-35% of patients have head and neck cancers and 30% sarcoma, chordoma and chondrosarcoma of the skull base and the spine and the pelvic region. 11% of patients ocular melanoma. So you can see our experience about radiation. We treat 15% of patients in this setting. So in the right side, you can see the approved indication by the National Health System. So this means that we can treat patients only within these clinical conditions. Other potential indication need to be discussed within a multidisciplinary tumor board. So here the clinical activity runs from Monday to Friday, 14 hours per day. So we have 2 daily shifts and night shifts and weekends are dedicated to research, quality assurance, upgrade, and machine maintenance. You can see in this table an overall performance parameters of the last 4 years. You can see that we treat in average 43 patients per year with more than 10,000 RT sessions. So what are the current clinical program. So we aim to expand, to implement scientific and clinical network. We are developing strategies for personalizing radiotherapy, including the optimization of energy deposition in the tumor. We are studying what are the burden of late toxicity in long-term survivor patients. We are developing biomarker-driven trials, and we are exploring the combination within particle and immunotherapy. And more recently, we are studying a potential phase 2 study for Boron-Neutron Capture Therapy. So regarding the network, our facility has currently a pivotal role in JANE2. JANE2 is a joint action on network of expertise, is a European action that follows JANE1 and emerged as part of the implementation of Europe's Beating Cancer Plan launched in 2021. You can see that we have 7 networks of expertise. One of them is about high-tech medical resources. And all this domain is, so the leader is represented by Unicancer, Region Zealand, but we have a work package on innovative radiotherapy so far, more than 22 member states and 67 institutes participated in this project. So the final aim is timely and sustainable adopt and integrate innovative RT into clinical practice. So we have to define what is the future roadmap for implementing RT innovation. And we continue to collect real-world data within our clinical registry, REGAL, which is an open-ended prospective and retrospective registry, non-interventional multi-cohort study. We share some items, some feeds of this database with other database scientific societies. And within the E3+ project, we are developing a proof of concept feasibility study in order to do a picture, to do a snapshot about different planning and recording methods about carbon ion therapy. So we continue to enroll patients within a multi-center international clinical trial. So this is the SACRO trial mentioned before by Piero, and Piero will present this work to the next PTCOG. Another study is led by Mayo Clinic, and this is a comparative effectiveness parallel prospective trial. We are contributing, so far we have enrolled 4 patients, and we are working also with Japanese colleagues. We have just published this paper on a specific selected clinical scenario, oligometastatic persistent or recurrent ovarian fallopian tube cancer patients. So, and yet another international consortium we are participating in is Stop Storm consortium dedicated to the STARS, to stereotactic arrhythmia radioablation. We are performing a trial with the use of proton therapy in a single session and under the behalf of this consortium. So few data are available on long-term survivors. So we have this study. We have just concluded the patients' enrollment. We have present. So this is the aim of this study. This is a cross-sectional study. We aim to collect data about quality of life and late toxicity for patients patients with brain tumors, head and neck tumors, and skull-based tumor treated from 2011 and 2018. And these questionnaires, quality of life questionnaires, were collected through telemedicine, and the preliminary data on 21 patients were presented to the ESRO 2024. Okay, moving towards the issue of biomarker and predictive models after particle therapy, we have designed the Galactic project in order to investigate the utility of AI-based model after particle therapy treatment. So the aims are to develop and evaluate the performance of these models in predicting treatment outcomes, both for disease control and for toxicity, and to assess AI-based approaches for optimizing, for facilitating radiological and radiotherapeutic processes. So here are some examples from ongoing projects. So specifically, ADC first order radiomics features provided a prognostic role as early biomarker in ACC treated with carbon ion therapy. So here if we combined multimodality imaging with the dosimetric map, we can use these data as input of a UNet-based deep learning multimodal in order to investigate the brain radionecrosis after proton therapy. So now addressing the issue of optimize energy deposition in the tumor and reducing the unnecessary doses in the healthy tissues. So one of potential way is represented by giving radiation, by giving carbon ion therapy through the simultaneous integrated boost. This is a typical method for photon-based radiotherapy. We have demonstrated the feasibility of this approach in silico, and currently we are running this trial. We have enrolled 10 patients, so the RBA was calculated using the LEM model. So, however, we are considering other approaches to improve energy deposition. The approaches are included in the precision project. The study is designed to have plans comparable in terms of dosimetric quality and robustness, both intra and interfraction. So you can see that this is a nominal planes, and here we have LET optimized plane. So you can see that we focus on ACC, so adenoid cystic carcinoma patients. You can see that we can increase the minimum LET to GTV from 40 to 68. So, and we can spare the temporal lobe. We can optimize the LET distribution according to hypoxia region. Hypoxia is a hallmark of radioresistance, and in these projects called IROC, we are developing a comprehensive hypoxia signature, starting from a retrospective series of patients with head and neck HPV negative OPC cancer from the National Cancer Institute of Milan, and we will perform a pilot study testing this signature for selecting patients for a mixed beam approach with carbon and protons, with carbon and photons, or a full course of photon-based radiotherapy. So we are working also on the combination of immunotherapy with carbon ion and protons for patients with metastatic but stable disease after the first line of immunotherapy, so disease with carbon, and due to the advances in neoadjuvant immunotherapy for head and neck, we are testing pembrolizumab in perioperative setting for a specific site, for a specific histology for sinonasal cancer. The last slide, we under the current expansion phase of our facility, we will introduce a new technology, a BNCT. So this is a biological targeted bimodal radiotherapy, and we are developing a phase 2 trials in order to obtain the BNCT as a clinical application. Thank you for your attention.
Thank you, Esther. We have just time for one burning question from the audience. Okay.
I just would like to know a little bit about this galactic project of biomarkers. So what type of biomarkers you're
For the
dose effect, short-term effect, long-term effect, just curiosity.
So the endpoints can be different according to the type of biomarkers. So for ACC, this is for the adenoidocystic carcinoma, we are evaluating ADC for local control, but in the same time we are evaluating ADC of healthy tissues for determining late side effects. Okay, so we have different endpoints and we use different potential biomarkers.
Thank you, Esther. Okay, at this point I will give the floor to my co-chair, Professor Semi Harrabi, who is director of the Heidelberg Heavy Ion Therapy Center in Heidelberg, and will give a presentation about the indication in Heidelberg.
Thank you very much, and good morning. It will be my pleasure to share a little bit of the experience of our clinical routine and some of the research ongoing at the HIT facility. Our facility is fully integrated into the university hospital, which has a very long history. It was founded already in 1386. And we treat as a university hospital in total roughly more than 1 million outpatients distributed over 9 clinical departments and 63 different clinics and institutes. This is an overview of a campus. It's basically our own part of the city called Neuenheimer Feld. And I like to say we're just sitting in the center, in the core of this so-called clinic ring. So we have all the disciplines around us. It's the surgical department, gynecology, children's hospital, ENT, neurosurgery, and internal medicine. And also on campus, obviously, there are many research institutions. Just to name one, for example, the DKFZ, with which we have very close collaboration. And just here in the middle is the HIT facility. Where do our patients come from? The catchment area is quite wide since we're a specialized oncology center. 1/3 comes actually indeed from the city of Heidelberg itself. Then another third from the metropolitan region, which is Mannheim, Ludwigshafen, Heidelberg together. And most other patients are coming from Germany. Of course, we also get referred a couple of international patients, and we try to treat them all under one roof. In Heidelberg, we have the NCT, the National Center for Tumor Diseases, which is a comprehensive cancer center with multidisciplinary tumor boards. There are 27 different tumor boards with dedicated research programs ongoing, and basically all our patients are also discussed in these tumor boards. It's not the same way as Piero said. We also need those tumor boards to strengthen the application for reimbursement, but gladly we have contracts with many insurance companies, and there's a long list of indications accepted. But if it's an indication which is not on that list, we definitely need to have this tumor board. But yeah, I mean, it's common sense that every patient should be discussed in an interdisciplinary way, offering him the best treatment possible. This is an overview of our department in general. We have 22 attending physicians, 26 resident physicians, more than 78 RTTs, 40 nurses, 12 dedicated medical physicists at the HIT facility, 22 for our photon department. We have a ward with 62 beds. We have a huge research department, biomedical physics, data scientists, clinician scientists, translational research, a clinical study center with study nurses, etc. Our equipment covers the whole spectrum of precision radiation oncology. We have 5 LINACs, 1 tomotherapy, an MR LINAC, CyberKnife, a brachytherapy unit, intraoperative radiotherapy, and of course, and finally, I'm talking of what you're most interested in, also the ion beam therapy center. Per year, as a department, we treat between 4,000 to 5,000 patients. As I said, we have our own ward with 62 beds and our own diagnostic department with 2 CTs, 2 MRIs. The PET-CT, I need to cut that. That's not any longer existing, but still ultrasound. Looking at the operation at HIT, it's 24/7 running. The main time for patient treatment is between 8 in the morning and 10 in the evening. Just before and afterwards, there's a QA block for medical physics. And then usually in the nights, we conduct experiments, optimizing accelerator settings, and then QA of the accelerator itself is done early in the morning. This is an outlay of our facility. We are synchrotron based. We have 3 permanent ion sources installed, currently protons, carbon ions, and helium ions, which are all used for clinical treatment. For experimental purposes, we can also connect other ion sources, such as oxygen, for example. There's a small LINAC accelerating the particles to roughly 10%. And then here our synchrotron, which is able to accelerate the ions up to 75% of speed of light. And then we have 3 treatment rooms, 2 with a horizontal beamline and 1 with a full rotating gantry, a heavy ion gantry. In room 1, we have a CT on rails for 3D image guidance. Just next to the treatment rooms, there is an MRI with a shuttle equipped to it, so we can image the patient in treatment position and then shuttle him directly to one of the treatment rooms. And for experimental purposes, there's also in the QA place, in the experimental room, an online MRI on rails, because currently we're investigating the potential also of MR-guided particle therapy, both off and ideally online. Our center opened in 2009, just in the end, November. So last year we had 15th anniversary. This year we will probably reach the 10,000 patients treated. So end of last year it was roughly 9,400 patients that have been treated in our institution, both with protons and carbon ions. And looking at the 3-year period, the numbers haven't changed so much in the last 3 years. I just recently checked them. It's roughly 50-50, quite similar as Esther has shown us for CNAO, 50% protons, 50% carbon ions, and then there are a few, as we already have seen the concept, for example, for adenoid cystic carcinoma, where we treat a combination of both the primary elective node irradiation with protons, followed by a carbon ion boost. But the most frequent entity that we treat is indeed adenoid cystic carcinoma, both in the primary situation as well as for recurrent disease. And then another focus of our institution is the treatment of pediatrics. I won't go too much into detail for pediatrics because later on there is also a talk about pediatrics and whether there's a role for carbon ion and helium ion for pediatrics. So I will quickly skip that. Of course, our goal is to broaden the knowledge about carbon ions. And how do we do that? Ideally, if we enroll as many patients as possible into prospective interventional clinical trials. Of course, almost any patients, more than 95%, are enrolled into a registry, so enabling us to do some retrospective research, but we also have a very long list of prospective interventional trials, evaluating the potential role of both carbon and protons, and more recently also helium. So far, we have enrolled more than 1,000 patients into these prospective trials. We try to push the amount of patients as high as possible. End of last year, we were able to push that to 50%. So end of December, 50% of our patients have been treated within clinical trials. I will just pick a few, since there are other colleagues also here from Heidelberg who will give some insights into the biology research, into the physics research. So I will just pick a few clinical trials. Piero mentioned it before. We used to treat always the elective nodes for adenoid cystic carcinoma, which is, as I said, the mainstay of indications that we treat. But we are also switching and evaluating whether we can get rid of the elective node irradiation and perform the treatment with carbon ions only. In this prospective trial, we compare it actually against our standard of photons plus carbon ion boost and carbons only for nodal negative adenoid cystic carcinoma. Just as one representative for the clinical trials ongoing with carbons. For protons, we also have clinical trials. I just wanted to highlight this trial, which we call Indigo trial, which is a model-guided optimization for proton. I know we could probably fill a whole symposium of talking about protons and variable RBE, etc. This is our candidate to gain a little bit more knowledge about variable RBE in protons. And of course, which we are very proud of, is the helium ion program that we just started. In the beginning, we lay out the roadmap of helium ion, so it's a whole ecosystem that we developed to bring back helium to clinics. And that kept me quite busy over the last year, or a little bit more time, because the bureaucratic jungle in Germany wasn't so easy to overview. And just on the right side, this was the list of documents I needed to prepare to the federal authorities in order to be allowed to conduct a clinical investigation which wants to demonstrate the safety and performance of our medical product, which is our accelerator basically, which hasn't been changed over the last years and hasn't killed so far any patient, but still we have to go through all that effort. But we will hear more about that in one of the other talks. Of course, MRI is a big topic. We have MR-Linacs, the fusion of image guidance online and treatment. We're also looking into the potential for particle therapy. As I said, just down the floor, there's an MRI where we can shuttle the patient. We have started first with offline image guidance, co-registration to go for adaptation for the patient, because the resolution is so much better, especially if it's in the treatment position. Of course, there's also the potential to calculate synthetic CTs from that. So down the line, our vision is to go for MR-based only treatment planning and to get rid of the CT scan. And we don't want to get stuck with offline MR adaptation, which is really nice and then well working. Usually if we do imaging, and we see that there's the need for adaptation. Latest within 24 hours, we will do a plan adaptation and treat the patient with a new version of the plan to make sure that we achieve the highest accuracy. But we are also at the brink of pushing it to daily adaptive radiotherapy for certain indications. Hepatocellular carcinoma is a very good candidate because we have a different approach there. We go for strong hypofractionation. We usually just have 4 fractions that we treat those patients, and there we can go through the whole workflow, imaging the patient on a daily basis with MRI, checking the anatomy, and then ideally bypassing it for adaptation. Currently, it's just a verification that the dose distribution is acceptable on the daily anatomy, and then hopefully very in the near future we have the potential also to online adapt, because with all the software, with the support of AI in organs at risk contouring, replanning, etc., the planning process is not the bottleneck anymore. It's just then bringing the plan to the machine if you want so. But in the MR project, more is ongoing. Of course, we are in the lucky position that we have a gantry and we can rotate the beam around the patient. But as many of you are also looking into other solutions like upright position, we are also looking into a capsule system. Why rotate the beam if you can rotate the patient, to see if there's a role to find other possibilities for beam angulation. And then also what Esther said, the potential for LET optimization, especially for pancreatic cancer. I just wanted to show this because there's a dedicated session on pancreatic cancer later on. This is something that we're definitely looking on. And yeah, there's only so much you can squeeze in into these 15 minutes. There's a long list of research ongoing, and I can't cover everything. Biological model, the renewal of LEM model, going to MMKM, introduction of new beam modalities like helium, multi-ion therapy, of course, MR guidance, flash arc, etc., you name it. So there's a long list, and actually I see there's one slide missing, because this is nothing that one institution can do alone. And actually I wanted to show our integration in the European or in the international network, because we appreciate the common research that we are doing, because we can tackle those problems only if we do that together. And that's it. Thank you.
Thank you, Semi. Very nice talk. So we have time for one question.
Just half a question. I don't see any PET scan as verification. It's supposed to be also something quite appealing to do as far as heavy ion.
That's right. I had it on the list of equipment for the imaging department. We used to have a PET scanner just next to it, and in the beginning we did a lot of PET verification right after the treatment, and Katja Parodi and her team did a lot of investigation and development there. But due to other research projects, we skipped that, and yeah. It's not in the focus currently.
Mm-hmm. Okay, thank you.
Okay, thank you, Semi.
Okay, then we'll continue with the program. It is my pleasure to introduce Professor Yamada, the head of the National Institute for Radiological Science from Japan, who will share the Japanese experience.
Sorry. Well, thank you, Chairman, and so Dr. Fossati, for kind introduction. Hey, I'm happy to have opportunity to present at Hadrontherapy for Life in Caen. My title of today's my title for the presentation is Clinical Experience and Future Topics of Carbon Ion Radiotherapy at QST. I have no CY. So the characteristics of heavy ion radiotherapy are favorable dose distribution and enhanced biological effect. So these characteristics make it possible to deliver high dose in a single fraction, resulting in a shorter treatment period. I'd like to show one case representing the advantage of CIRT. So this is a kidney cancer case. CT scan shows lung tumor in the left kidney. The patient received CIRT. 10 years later, tumor completely disappeared and renal function was preserved. This case demonstrated excellent dose distribution of carbon ion beam. So the slide shows the current indication for CIRT. So red indicate national health insurance, blue indicate advanced medical care, and green indicate clinical trial. Currently, 11 diseases are covered by national health insurance. As advantage medical care, we treat esophageal cancer and oligo, liver metastasis, and lung metastasis, and lymph node metastasis. So we are also treating breast cancer as a part of clinical trial. So from 1994 to 2024, nearly 16,000 patients were treated at QST. So this graph indicates the number of the patients at the QST according to the tumor site. Disease shown red are covered by public insurance. Approximately 80% of all cases were covered by insurance. The most common organ are prostate and bone and soft tissue, and head and neck, and lung, and pancreas, and liver. Currently, QST treat more than 900 patients per year. So this slide shows the treatment duration of each cancer. So lung and breast cancer are irradiated in single fraction. That is, the treatment was completed in 1 day. The average number of treatment per patient for CIRT is as few as 11, and the average treatment time is as short as 80.5 days. So I'd like to introduce the treatment result of each cancer at QST. First, I'd like to introduce the bone and soft tissue sarcoma that is the first covered by national insurance. So CT shows the tumor indicated by the red circle in the column, but 10 years after CIRT, the tumor disappeared, and the bone was also formed. So this is a treatment result of CIRT for osteosarcoma. So 5 years local control rate was 61%, and 5 years overall survival rate was 32%. So this table shows the reported outcome for osteosarcoma. The 5 years overall survival rate of CIRT was better than other institutes. In case smaller than 700 milliliter, which is similar in size to operable case, the 5-year survival rate was 45%. So this is the same as surgical result. So next is chordoma. The CIRT is quite effective to this small. You can see the case with the sacral chordoma, which has obviously decreased in size, the MRI image of 5 years after CIRT. So we conducted a collaborative study comparing our case with those of the Mayo Clinic. So this graph is overall survival of comparing Mayo Clinic's of X-ray data and our CIRT data. So CIRT is a significantly better survival rate compared to X-ray. So this graph compares also carbon ion and surgery. So CIRT could provide a comparable survival rate with surgery. So on the table is a summary of this comparative study. So peripheral motor neuropathy was much less in CIRT. The pancreatic cancer is an extremely challenging disease with a very poor prognosis. The development of chemotherapy has slightly improved the result. So this tumor is also a good candidate for CIRT. The image shows the locally advanced pancreatic cancer. After 1 year of CIRT, the tumor shrunk and became resectable, but the patient refused surgery. The CT scan after 8 years CIRT showed the tumor has disappeared, and the patient symptom-free and in good health. So the 2 years, this table shows the reported radiotherapy result. The 2 years survival rate for CIRT is higher than X-ray or proton. CIRT is characterized by the fact more patients survive longer than 5 years compared to X-ray. So further dose escalation studies are currently ongoing to further improve the outcome. So we could establish a short course of CIRT also for hepatocellular carcinoma, that is 2 fractions in 2 days. So this is a patient with giant liver tumor, more than 10 centimeter diameter. After 2 fraction CIRT, the tumor was apparently decreased in the size. So there has been no severe adverse event until now. So comparing local control rate and survival rate, so this primary liver cancer with proton therapy at the Japanese Institute, they are comparable, but more ordinary fractions were used in proton therapy. So it can be said that 2 fractions CIRT can offer similar result to proton therapy of conventional fraction in the treatment of liver cancer. So postoperative locally recurrent rectal cancer is another good candidate for CIRT. So generally, the patient referred to our hospital are inoperable, like this CT scan. So such an advanced tumor is very difficult to be controlled by X-ray or chemotherapy. However, CIRT is effective. As you can see, the bottom table, the result of CIRT seems even better than surgery for operable case. So we are actively conducting collaborative research with Korean Institute. The left graph is a survival curve comparing the result of X-ray therapy at Yonsei University in South Korea and CIRT at QST for the treatment of locally recurrent rectal cancer after X-ray irradiation. X-ray a black dot line and CIRT line is red. The survival rate was shown to be significantly higher with CIRT. The right graph compares the result of post-operative local recurrence of rectal cancer between preoperative chemotherapy and surgery at Mayo Clinic, and CIRT alone at QST. So the median OS was 4.5 years in the CIRT group and 2.6 years at the CMT group, indicating that CIRT was significantly better than CMT. In Japan, absorbable PGS spacer was developed the treatment of tumor in contact with a gastrointestinal tract. So this was approved for National Health Insurance in 2019. Here we present the case of 58 years old male diagnosed with a left pelvic recurrence after rectal surgery. As a tumor, in contact with the intestinal tract, CIRT would be difficult, and PGS spacer was inserted. The 2 months after insertion, the CT density of the spacer changed, but its thickness remained unchanged. By 3 months, the spacer was gradually absorbed, and 5 months, it had completely disappeared. So clinical trials of carbon radiotherapy for breast cancer are ongoing. The first clinical trial consists of four fractions and followed by routine surgery. The breast 2 trial consists of 4 fractions followed by whole breast irradiation. Now the breast 3 trial currently being performed is a single 50 gray irradiation only. So moreover, so we could obtain the quite impressive result regarding the incidence of secondary cancer after CRT for prostatic cancer. The horizontal axis, the years after treatment. The vertical axis is the incidence of secondary cancer. So red indicate surgery. The green indicate so X-ray, and blue indicate CIRT. Compared to X-ray, the incidence of secondary cancer caused by CRT is significantly lower. So in order to spread the use of heavy ion radiotherapy, it is necessary to reduce the size of the device. So original device size is soccer field. The size of the third generation is 1/3 of the first generation. We intended to reduce the size to tennis court so as to install the device in an existing hospital. So we are using some superconducting coil technology to reduce the size of synchrotron, and laser acceleration technology to reduce the size of injector. So construction of fourth generation heavy ion facility began at QST. To achieve higher therapeutic efficacy, the quality of radiation, LET, must be increased. A multi-ion method was developed at QST. The tumor is irradiated with a combination with oxygen in additional carbon ion, increasing the LET value. The world first multi-ion irradiation treatment for osteosarcoma, a highly malignant bone soft tissue tumor, was conducted at QST Hospital in 2022 using a multi-ion source developed at QST. The minimum LET for carbon ion was 31 keV, but adding oxygen to carbon, the minimum LET could be increased to 41 keV. So an MRI, 3 months later, showed that tumor size was significantly reduced. Compared to conventional treatment with carbon ion beam alone, so this method is expected to improve treatment outcome for radioresistant cancer. So as non-cancerous radiation treatment using the heavy ion beam, so we performed the world first arrhythmia irradiation therapy using a carbon ion beam to treat fatal ventricular arrhythmia. So in the first case of clinical trial, the frequency of arrhythmia decreased steadily as shown in this graph. So this arrhythmic effect has to be demonstrated in the basic research to associate it with application of connection, atrial connection 40 and ventricular connection 43, which is a gap junction proteins. So we are able to obtain the favorable initial effect of anti-arrhythmic effect. So we believe that these results suggest new possibility for the future of heavy ion radiotherapy. Okay, this is a summary. Thank you for your consideration.
Thank you so much for sharing the experience and giving us an overview of the entities treated.
Thank you very much.
Is there any question, any comment you would like to ask?
Yeah, thank you for this presentation. I was really impressed by the results of survival for locally advanced cancer. With 30% of 5-year survival, was there only locally advanced cancer, or was all stage of pancreatic cancer?
But including borderline.
Okay.
Yes, borderline plus locally advanced pancreas.
Thank you.
Thank you very much.
Thank you.
Thank you.
So it is now my pleasure to introduce Professor Ohno from the Gunma University. He will give a talk about the clinical experience and future direction of the Gunma Center.
Okay.
Thank you.
First of all, I'd like to thank the organizing committee for inviting me this symposium. So, okay, this is my disclosure. So Gunma University Heavy Ion Medical Center is first university hospital-based facility in Japan and supported by Japanese and local government and providing medical staff to other CIRT centers in Japan. And multidisciplinary approach is available because some of the centers are single division in Japan. So this slide shows the number of patients who received particle therapy in Japan in 2003. In 2023. Almost 11,000 patients underwent particle therapy. For carbon ion therapy, 5,600 patients were treated across 7 centers, while for proton therapy, 5,300 patients were treated at 19 centers. So on average, each carbon ion therapy center treated over 800 patients, with some centers treating as many as 1,200 patients. So this is annual patient number at Gunma University. This slide shows, almost 800 patients are treated recently. And even during the COVID-19 pandemic, the treated number increased. This slide shows breakdown of cancer types at Gunma University. The most common site was prostate, followed by liver, pancreas, sarcoma, and lung. Okay. The insurance system is revised every 2 years in Japan, as Dr. Yamada presented. So in my talk, I'd like to focus on these cancers, four cancers. So post-radiation osteosarcoma is well-known X-ray resistant tumors. So here, I'd like to 2 cases. Both cases had a past history of radiotherapy for pelvic malignancy, but tumors were well controlled after carbon ion radiotherapy. So this, which is very impressive for me as a radiation oncologist. And this is the youngest patient, 1-year boy with chemotherapy-resistant undifferentiated sarcoma. Head and neck tumor was well controlled, but bone growth disorder was inevitable as informed before treatment. And long-term observation will be necessary, of course. And in pediatric cancer treatment, one may concern secondary cancer after carbon ion radiotherapy. This slide shows neutron dose comparison between proton and carbon and passive and scanning. So neutron dose from carbon ion beam is lower than proton, and the active scanning beam is lower than passive beam. Thus, the active scanning with carbon ions produce lowest neutron dose, which is our rationale for treating pediatric sarcomas and also advantage for treating patients with cardiac implantable electronic devices, CIS. So many patients are sent to our center from other carbon ion center. Okay. This slide is overlapping with Dr. Yamada. Please look at the right figures. In the phase 1 study, PGA breaks down through hydrolysis and is absorbed by the body over time. And this slide shows how the volume of the PGA spacer changes during the treatment, after treatment. Okay. The gradual absorption helps maintain a safe distance from the GI tract. And this this is a sacral chordoma pushing the rectum forward. So this is not indicated for carbon ion radiotherapy. So we asked surgeon to insert a PGA spacer between the rectum and the tumor. So the steep dose gradient effectively spared the rectum from the high dose exposure. Okay, next. So I'd like to move on to the head and neck cancers. So this is adenoid cystic carcinoma of the right maxillary sinus invading to the orbital cavity. So no evidence of tumor recurrence 3 years after carbon ion radiotherapy, and light blindness occurred at 14 months, which was unavoidable as informed before treatment. However, left visual function was well preserved. So tumor characteristics are quite different between Japanese statistics and carbon ion community. So histologically, squamous cell carcinoma is most common, while non-squamous cell carcinoma such as adenoid cystic carcinoma, malignant melanoma, and adenocarcinoma in carbon ion radiotherapy. So for primary site, oral cavity, pharynx, and larynx are common site. But in carbon ion radiotherapy, nasal and paranasal cavity was most common. So this table summarizes local control rate by tumor histology. So irrespective of the histology, local control rate was favorable, ranging 70 to 90%. The survival sometimes decreased because the patient developed distant metastasis, especially in malignant melanoma. So we have studied those volume constraints in carbon ion radiotherapy for head and neck cancers. Here we present data on nasolacrimal duct obstruction, osteoradionecrosis, and intraocular hemorrhage. So recent our review includes those volume constraints on the brain, brainstem, palate, and optic nerve, eyeball, retina, iris, ciliary body, optic disc, nasolacrimal gland, tongue, palate, masseter muscle, coronoid process, maxilla, mandibular, teeth, and skin, many. And those volume constraints for thoracic and abdominal and pelvic regions are also under revision. So both reviews will be useful for the future clinical trials. So these slides illustrate the difference of those distribution between X-ray and carbon ion radiotherapy for the liver and lungs. The volume in the low to medium dose range is significantly smaller with carbon ion radiotherapy, making it safer even for larger tumors. So for example, interstitial lung disease is one of the risk factors for developing severe radiation pneumonitis after radiotherapy. So this table shows the incidence of radiation pneumonitis after SBRT, proton, and carbon ions. The incidence of grade 2 or 3 or more was lower in particle therapy. So carbon ion radiotherapy is safe for patients with interstitial lung disease, but should be managed carefully with respiratory medical doctors. So this slide shows overall survival after carbon ion radiotherapy for operable patient, operable early stage lung cancer. Okay. Operability was determined by tumor board. On the right side, survival data after surgery was shown. So almost comparable survivors by clinical stage were obtained, although comparison is not fair, but both registries showed the similar clinical outcomes. Okay, next is cervical cancers. This is overall survival according to the figure stage in cervical cancer. So adenocarcinoma histology is poor prognostic factor in locally advanced cervical cancer. So NIRS has conducted several dose escalation study, and this figure shows established protocol. During the carbon ion radiotherapy, multiple treatment planning changes were necessary to spare the GI tract. In addition, vaginal packing with cotton or gauze was used to displace the rectum. With the standardized protocol, local control was improved to 74% at 2 years, but still insufficient for both local and distant site. In addition, several patients developed late GI toxicities, including perforation and stenosis. So, I wanted to improve such data, and we conducted a phase 1 study to evaluate safety and feasibility of combined carbon ion radiotherapy and image-guided brachytherapy for locally advanced cervical cancer at Gunma University. So in our treatment regimen, half of the carbon ion beam boost radiation was replaced with brachytherapy. And during the GTB boost, a vaginal immobilization device was inserted to keep the upper vaginal position and to displace the rectum from the cervical tumor. So this is a vaginal immobilization device originally developed at Gunma University. OKT it means Ohno-san, Kubota-san, Tashiro-san. Okay. And okay. This device was approved by Japanese FDA. Okay. The OKT device displays the rectum and spare the dose to the rectum. And film is inserted inside, galvanochromic film, to confirm the dose verification. In addition, this device is also possible for PET verification. Okay, this slide shows dose distribution of our protocol. The patient received whole pelvic radiation with 36 gray in 12 fractions, followed by boost to the primary tumor and lymph node metastasis. Then image-guided brachytherapy is initiated. Okay, this slide shows the clinical outcomes of carbon ion radiotherapy for locally advanced cervical adenocarcinoma at Gunma University. The 3-year local control rate was 100%. Progression-free survival was 57%, and overall survival was 89%. So no patient developed grade 3 or worse late GI toxicity. So the current our challenge is to reduce the distant metastasis through the new combination with systemic therapy. So since this March, we initiated a study of pembrolizumab in combination with carbon ion radiotherapy for locally advanced cervical adenocarcinoma by supporting Merck company. It references Keynote 18 trial with the previously established schedule of chemoradiotherapy, carbon ion radiotherapy. Pembrolizumab administered concurrently and continuously for 2 years. Okay, cervical cancer treatment can provide an opportunity for evaluation of biological response using tumor tissues. So tumor biopsy after first session of carbon ion radiotherapy demonstrated clustered double-strand breaks by super resolution microscopy, which was different from those with X-rays. So through the clinical trials, we also investigate the biological markers, immuno-related markers. So this female patient, another disease, had tumors in the pelvis and the right leg, 2 tumors. Carbon ion radiotherapy was provided only to the pelvic tumor, and she continuously received immunotherapy. During the immunotherapy, the leg tumor gradually decreased, and finally both tumors disappeared. So we expected a new combination with immunotherapy. Okay, this is my last slide. This is a famous doll in Gunma called Daruma. Your wish will come true. Please take a picture. Thank you very much.
Thank you, Professor Ohno. So we have time for questions.
So if we want a full success, it's white, the white color, mixture of every color.
Yeah, you have to buy everything.
So we are ready to start over again. It's my pleasure to introduce Professor Jacques Balosso from the University of Grenoble. He will make an overview of the path that led to the clinical indication for carbon ion here in France. So, Professor, the floor is yours.
Thank you very much. Thank you very much to you all to be here today, and thank you to the organizer to have invited me to speak about the way we define indication for carbon ion therapy for the different projects in France. So this process has lasted several years, as you will see, and it has been divided in different steps. The first step, and I will detail a little bit each step, the first step was the a priori definition of eligible tumors. The second step was a big attempt of epidemiologic studies with different possibilities. We use the French network of cancer register. We did a one-day survey in France and some other studies. And the fourth step was a discussion with expert boards to define what was the most important indication, to make a sort of priority, because you will see, as it has been, for instance, demonstrated by the previous presentation, that a lot of cases could be eligible for carbon ion therapy, hadron therapy, particle therapy, proton therapy, and so on. So we had to reduce these possibilities to a sort of short list with the highest priority indication. And then, sixth step, we use it for different purposes. First, to design the size of the former ETOILE project in Lyon. Second, to design a randomized clinical trial called PHRC ETOILE, made with the center of CNAO. And third, to advise the French Social Security about which patient could be reimbursed for such type of treatment. So the first point, which is very important, was the a priori definition about oncology concept for these eligible tumors. We named unresectable tumors, a high rate of local failure, and radioresistant tumors. Tumors with limited local regional stage, that's very important to reduce the size of the treatment, and tumor having a very precise definition with the different system of imaging, and I should say a low invasion process in the tumor region. That's very important to reduce the CTV, which is the toxical part of the treatment, and the possibility of precise repositioning, and in a way, at first, avoid mobile tumors. So the second, third, and fourth steps are summarized in this slide, which is quite complicated. So we started this process in 2002, and we stopped it in 2010. And through this process, you have the different steps I told you. So the basic criteria give us the possibility to probe the cancer register in France and to identify a lot of possibilities of treatment. Then we make a sort of one-day survey with this sort of list, a sort of table people could use in their department. And this one-day survey, as you will see in a while, the outcome was a lot of cases eligible for hadron therapy in France. And meanwhile, we did a probe of the international literature to have the standard of care and the state of the art about the treatment process and also the survival of these type of tumors, to have a baseline, of course, and to see or to estimate how we could improve this baseline. And then, through a very stringent choice, we reduced this list, you will see how, to a very high priority short list to make the next step, which is the clinical trial. So about the one-day real-life survey. It was inspired by the survey we did at that time for the AIDS. So you remember maybe that. One day you should see if in your health department you have some patient with human immunodeficiency syndrome. So we think that it was a good idea because a certain day in a radiotherapy department, you have 10% of the patient of the year at that time. Now the treatment are getting shorter and shorter. It's maybe not not maybe true now, but it was the case in 2003. So we gathered 21 institutions, and one day, a single day, this institution searched their medical reports on treatment. It was 2,438 files. On these files, 354 was eligible for some kind of hadron therapy, and by successive extrapolation, we could conclude that about 17,000 patients per year could receive hadron therapy in France. It's quite a big country. And among them, 7,500 carbon ion therapy. That's a huge number. So to reduce this number, of course, we proceed by sort of cancer board, tumor board, if you like. We gathered at least 100 doctors. We made a series of meetings in different parts of France. One has been taken in Institut Curie, another one in Bordeaux, and so on and so on. And we decided to privilege and to choose these indications. And for each of them, thanks to the previous epidemiologic studies, you have the expected number of this case in France. So that's not an epidemiologic picture. That's a choice of indication, because in each indication you have a reduction. It's not all the cases of that type of tumors. So this short list is the following: adenoid-cystic carcinoma, roughly 400 cases per year in France; mucinous melanoma, 40; chordoma and chondrosarcoma of the skull base and spine, 70, and so on and so on. Soft tissue sarcoma, small cell lung cancer of very specific case, pelvic adenocarcinoma, mainly relapses of rectal cancers, and hepatocarcinoma of large size, but in France, the eligible type of hepatocarcinoma are quite rare. So if we compare at that time this short list with what was treated in the same time in Japan, you see it's a very restrictive choice among the indications which were treated at NIRS at that time. And for instance, there were no prostate and no lung patients in that list. So we applied this list for the following steps. And first, we decided that the size of the carbon ion center in France, the ETOILE center, should be able to treat about, as you have seen on the previous slide, about 1,000 patients a year. That's a 3-room center. That was the size which was expected. And a thing which was very important, in 2010, the Ministry of Health in France demanded to the Groupement of Coopération Sanitaire Étoile to organize a clinical evaluation of carbon ion therapy in France. That was not very easy. We didn't have a center. So we proceed the following way. We choose our list of indication, and we set up a PHRC, which is a type of clinical trial which is supported by public money coming from the Ministry of Health, but basically they are coming from the health insurance. And with this type of study, we can open different centers in France, and we choose to randomize the patient. So the patients were coming from at least 20 centers from France, and they were randomized. I will show you what was the process to do that. And they were sent to the CNAO in Pavia, and all these patients from this study have been treated by our colleagues of Italy. So the process was a little bit specific. When the patient was identified to be eligible regarding to the criteria of the study, the medical record was first submitted to the CNAO team, and the CNAO team said, yes, it's a good indication for carbon. No, it's not a good indication of carbon. If it were a good indication of carbon, then we proceed to the randomization. And if the patient was in the carbon arm, they go back, not the side, go back. The patient went for the first time to the CNAO for his treatment, and the others were treated in France. So this way, we proceed. So we were had also the possibility in the reference arm to go in proton therapy through a specific process using the evaluation of the NTCP. So this study has been authorized in 2012, something like that, and we treat the first patient. We included the first patient in December 2017. We need a lot of time to set up the study because it was a transnational, not an international, a transnational study. Patients from a country were in the study treated in another country, which is quite original. And we opened about 20 centers in France. And you see on this picture the figure of the study when we have been asked by the sponsor to close the study due to a slow accrual. We were just 5-year accrual. There are some studies which has been presented in this room this morning, which are open since more than 12 years. But it has been like that. We have foreseen to randomize 250 patients, and after 5 years, we only have randomized 30 patients upon 60 eligible patients. You see there's 50% lost, and that was the same from the beginning to the end of this study. So now the inclusion are stopped, the patients are still followed, and the study will be ripe, if I may say, in 2028. So meanwhile, when we decided to start with these studies, the health insurance in France authorized us to send for carbon ion treatment, either in Heidelberg or in Pavia, other patients having the same indication waiting for the opening of this study. So we have a dual cohort in France, one in the PHRC, this one, you see, with the main indications, carcinoid cystic carcinoma, chordoma and sarcoma in the respective frequency we were expecting. And we have an out-of-study cohort, which is presently about 60 cases with the same distribution of type of tumor and some others. So that's the experience in France. We will be able to combine some of these patients with those in the future. We have published the design of the study, of course not the results. And we plan, as I told you, to introduce some of these patients out of the PHRC-12 in the experimental arm of the PHRC-12. 13 patients are exactly in the same situation and could have been included in that treatment, except they have not been evaluated a priori by the CNAO, but they have been treated, really treated by carbon therapy, either in HIT or in the CNAO. And some of other patients, the ones which are in red, are re-irradiated patients. You have seen that it is a strong demand of carbon ion therapy at the present time. So that's the story of the choice of the indication for carbon ion therapy in in France, I may say, and in the adventure of ETOILE. So as a conclusion, we could say that so far the French approach was mainly based on relative radioresistance and of tumor of predominantly concern of local control, which is quite a specific point of view, which is consistent with what was done at that period in other centers. It is also a matter of shortage management policy because we have reduced this list very, very shortly, and we were oriented to, we were not able this way to propose disruptive concept as, for instance, enhancement conservative treatment, which is certainly a good approach, maybe the best, and also complementary with surgery. It was really a comparison of a certain type of radiotherapy with another type. With the present orientation, the case is of highly metastatic tumors, for instance, as lung cancer or pancreatic cancer were completely out of the scope. It's why I didn't speak about pancreatic cancer, for instance. And I hope that renewal challenges will be discovered through this meeting and that new orientation will be given. So thank you very much for your attention.
Thank you, Professor Balosso. So time for questions, if very quick one. Oh, okay. I can just make a quick question.
Yes, of course.
I remember that at the time that we were doing the trial, enrollment trial for treatment at CNAO, there was some difficulties. There were some difficulties in making all the oncological community know what we were doing and which were the indications. So kind of we were referred only very advanced cases or mainly very advanced cases. So the question is now if you have a plan.
Still the same. You see on this picture that some very big institutions perfectly aware of this study didn't include any patient. So there's still strong difficulties to make step forward. And I have the feeling that the demand of patients is also decreasing. The last years, we have seen less demands of the patient directly to the social security. So we have to move to make that known because all the new techniques of treatment, immunotherapy and so on are overflowing this concept. And I think that your question is very, very critical, very critical. We have to continue. I hope that proton therapy will help for that because when we are doing the tumor board for proton, we are seeing these patients and we are sometimes able to say, oh, that's an indication for carbon ion therapy. This way we can a little bit make a step forward, but it's quite difficult, I should say.
Okay, thank you.
Yeah, thank you very much. Then we continue, and it is my pleasure to welcome Ellie Light from the University of Liverpool, who will talk about the experience in the UK.
So, hello everyone, I'm Ellie Light and I'm a qualified radiographer from the UK and I'm currently completing a master's degree. So I'm just going to briefly explain the purpose behind my presentation, and it's just to present my systematic review which assesses the clinical indications for carbon ion radiotherapy. And to gain a greater experience, I actually visited the CNAO Centre in Italy, where I got to see how they planned using carbon ions and which patients that they treated, which was really beneficial for the UK, as we are trying to decide whether we are going to implement carbon ions or not in the future. And there needs to be a considerable mention to the new cyclotron in Normandy, which will hopefully revolutionise the use of carbon ions and hopefully provides prospect for collaboration with the UK to bring carbon ions to the UK. So since Kirby et al. Proposed a carbon ion research centre in 2020, there have been no further research assessing the UK's suitability to carbon ions. And with a growing international interest and promising clinical data, this is an advancement to explore. So Kirby et al. Discussed the option to establish a heavy ion centre with the opportunity for both carbon ions and flash radiotherapy, and concluded a strong consensus that a heavy ion centre, including carbons, is needed. However, there is a great need to quantify the clinical need regarding the different tumour types and patient demographics, which was explored in this paper. So the UK have recently opened 2 NHS proton beam therapy centres, which are currently in infancy, generating an evidence base. However, the UK is currently generating the next steps for carbon ion radiotherapy, and this is the first paper assessing the use of carbon ions in the UK. It's also important to note that a large contributing factor to having only protons in the UK was due to the accessibility and knowledge of the equipment available at the time. And most of you will be aware of the radiobiological characteristics of carbon ions that are arguably superior to both photons and protons. So this is just a quick brief. So the systematic review was to aim to quantify the UK's clinical need for a carbon ion centre, and this was assessed through various tumour types, through evaluating the overall survival and local control rates, amongst others, and then the need was further quantified in relation to the UK's incidence and mortality rates. And you can see the Prisma diagram there. So regarding the results, a total of 78 papers were included in the final analysis, and the tumour types were separated into strong, conflicting, and weak evidence regarding the clinical response values. This at the time was used in comparison to the UK's incidence and mortality rates, so there may be different opinions across the room, as we've seen. So it would be really beneficial to compare these results of the study with the plans for the Normandy Centre, just to see if the results are comparable. But I will be discussing a select number of cancer types today, and in the full review there are more than 14 different types analysed, and this is just an example of how the results were collated in a table, and then also the toxicities were also reported. So I'm going to be first talking about non-small cell lung cancer, and non-small cell lung cancer is becoming increasingly common in the UK, with radiotherapy being a common treatment option. And a study reported high efficacy for carbon ions in comparison to proton beam therapy for stage 1 disease. To quantify this further, more studies are needed. However, the physical properties of carbon ion radiotherapy may indicate high efficacy for non-small cell lung cancer treatment. So currently the UK uses photon therapy to treat non-small cell lung cancer, and there are a few studies comparing this with carbon ions. But importantly, reduced lung dose was seen for carbon ions with improved tumour coverage compared with 3D XRT and IMRT. And a more recent study in 2024 reported promising 5-year survival outcomes for operable low-stage non-small cell lung cancers with tolerable toxicities. However, due to the inconsistencies across the evidence base at the moment, it does possibly indicate a possible indication for carbon ion therapy in the UK due to the high mortality and incidence rates. And again, discussions on the use of carbon ions for non-small cell lung cancer will be valuable information for the UK to develop a carbon ion radiotherapy centre. So pancreatic cancer's known mortality is devastating, and the known level of hypoxia correspond to radioresistance, present radiotherapy as a challenging and arguable form of treatment. Moreover, in unresectable tumours, carbon ion radiotherapy has provided a therapeutic breakthrough with reports of encouraging overall survival and local control. The survival benefit is a great advancement and has attracted attention in the field of research, such as the recent clinical trials, including the phase 2 PAC study, investigating the efficacy of carbon ion radiotherapy in localised pancreatic cancer at the HIT Centre. And it's a fruitful area to commend multi-institutional and large comparative studies to further evaluate the efficacy of carbon ion radiotherapy, which creates an opportunity for the UK to also conduct and contribute to world-renowned research. Moreover, Normandy is in a great position to aid the development of carbon ion treatment for pancreatic cancer, which is an exciting prospect. And particularly in the UK, there is a great need to improve pancreatic cancer treatment and has the opportunity to dramatically improve cancer services and patient outcomes in the UK. So prostate cancer presented with a great clinical response with high overall survival and few and low toxicity, with high quality papers indicating a great clinical need. Importantly, the quality of life has also been reported to increase from baseline for select patients, which is a very important aspect. So the main question for the UK is the current use of photon therapy optimal for prostate cancer treatment? So photon therapy is largely used to treat prostate cancer patients in the UK, and although the well-known TRIP trial was associated with greater efficacy, there was also greater toxicity. And this emphasises more with the recent evidence suggesting carbon ions is superior to both protons and photons seen through the higher overall survival. So prostate cancer is being increasingly treated with stereotactic ablative radiotherapy in the UK, however is not the current recommended schedule. Thus comparative studies with carbonyls and SABR outcomes will be beneficial for the UK population to further quantify the use. Moreover, the current use of photon therapy in the UK can be considered suboptimal and possibly out of date. So the USA began treating prostate cancer with protons in 1976, and despite this, it has been argued that the increased cost, lack of randomized data, and comparison to IMRT, it's not sufficient to justify its clinical use in the UK. However, recent data has suggested excellent quality of life and effective tumour control, thus argues the need for recommissioning of proton therapy for prostate cancer. However, we should not ignore the strong indication for carbonyls, seen through high overall survival and large diagnosis rates. This does give rise to, and has been proposed, of a single funded centre for prostate cancer, which, although may not be financially feasible, the data cannot be ignored. So I'm now going to talk about chordoma and chondrosarcoma, which fellow colleagues here have displayed a great clinical response. So school-based sarcomas, such as chondrosarcoma, present a challenge in radiotherapy due to their proximity to organs at risk and associated radioresistance. However, carbonyls have appeared to provide a therapeutic advantage. There was also a reported decrease in neurological deficits with follow-up as long as 10 years, increasing the validity of data. And moreover, a study comparing clinical response for both protons and carbonyls for school-based chordoma reported similar overall survival values at 5 years. However, the overall indication requires larger and high-quality studies to then inform the UK's population, but does display promising clinical outcomes. And at the time, studies investigating osteosarcoma and tissue sarcoma and soft tissue sarcoma were fewer. However, we have seen today that they do display a great clinical response and suggest potential for safe treatment of soft tissue sarcoma. So the UK would largely benefit from collaboration with existing centres to establish the feasibility of this treatment. And for nobody having a particular interest in chondrosarcoma, this would be a great benefit and an area needed within research. So I'm just going to be discussing a few other tumour types. So nasopharyngeal tumours displayed a positive clinical response with encouraging overall survival and local control values. And at the time that this paper was published, there were no studies assessing the response for breast cancer with carbonyls. However, a study reported in December 2024 has provided the rationale for further research, and as we have seen today, on the use of carbonyls for breast cancer. And the proposed gain was emphasised in locally advanced or recurrent breast cancers, with the prospect of offering a synergistic effect when integrating immunotherapies with carbonyl radiotherapy, which is a great advancement. However, due to the large gap in the practice for breast cancer incidence and then the patients being treated and have access to carbonyl radiotherapy, further research is definitely needed, and it would be valuable to the UK's population. So there were 3 studies reporting the response for rectal tumours, with a multi-institutional study reporting a 2-year local control rate consistent at 94% across all 3 centres, with overall survival being between 80 and 100% for those papers. A similar retrospective study reported a reduced overall survival, but did indicate a possible safe dose limit. So this shows that carbonyls has a chance to improve survivorship and also shows that there is adequate safety. And I know we have a talk on this later, which will be really interesting, but when I was doing this paper, there were no studies of high quality to indicate the use of carbonyls for pediatric tumours, which was quite surprising, as in the UK we are treating some pediatric tumours with protons. This might be due to the literature for protons focused on more photon-sensitive tumours, whereas carbons are more photon-resistant, which may account for the undetermined dose of fractionation and the unanswered questions, but it would be great to learn more about it today. And so future research, so the evidence base for carbonyls is lacking in phase 3 trials, but the strength of evidence is increasing and the gap in research is also reducing. So for the UK, there have been tumours that have shown a strong benefit for carbonyls with also large populations. So there should now be discussions with partnerships and existing centres in the world to develop a carbon ion facility in the UK. And so you can see in the diagram above that the cancer types displayed in green have displayed a good clinical response with sufficient literature to support an evaluation to the UK's incidence and mortality rates. So this helps indicate the UK's radiotherapy team as to whether the use of carbon ions will be sufficient for the UK's population. And it's also important to consider that the mortality rates in pancreatic, liver and esophageal in the UK are very high. And due to the conflicting evidence at present for some of those tumour types, it would be worthwhile to commence more research with the aim to improve survivorship. So since my review, there have been more research on pancreatic tumours, which I'm really interested in. And importantly for the UK to be at the forefront of cancer care, the clinical benefit of carbon ions cannot be ignored and offers the UK great opportunity for research and wider collaborations. So this strengthens Kurt Biertal's proposal of a carbon ion centre, proposing the role of a research-specific centre or even a single funded centre. So finally, it would be valuable to discuss the clinical plan for the new centre here in Normandy, including the clinical indications for carbon ion therapy, given the potential comparability of patient populations. So I'm interested in exploring the treatment indications today and tomorrow, as it will be beneficial to assess how the UK's outcomes align with the plans for the newly established centre in Normandy and the centres around the world as well, to better inform the UK of the new treatments with carbon ions. So I'd just like to thank you for your time and congratulations to the team at Normandy. Thank you.
Wonderful presentation. Thank you very much presenting your meta-analysis. Are there any comments or questions?
I'm just curious, the two excellent outcomes you reported in pancreatic cancer, are they from Japan?
Yes. Very, very good research.
Okay, thank you.
Yeah.
Just a comment. Are you sure that phase 3 trial, randomized phase 3 trial, are the right way to demonstrate evidence for carbon ion therapy? You need to know that we speak about 90% of cases with rare tumors so far. This is the first one, the first comment. The second one, we have few centers worldwide. So maybe I think, and this is my opinion, that to run strong, well-designed international registry, so for collecting the real-world data is the only way to demonstrate evidence for carbon ion therapy.
You are correct.
Before you answer, I'm not sure, did everyone understand the question? I will shortly repeat. The essence was whether phase 3 trials is really the way to go for carbon ions, since we deal mostly with extremely rare entities.
You are correct, and unfortunately I can't answer your question to know exactly what the UK want to quantify their need, but definitely with the tumour types and the indications that we've seen in research, it would probably be not the best route to go down to implement it in the UK. But yes, thank you for your question. Unfortunately, I can't answer it at this time.
Again, thank you very much. And then on your last slide, you were emphasizing the need for future research and especially for collaborative research, also on pancreatic cancer. And I think this is quite nice transition, because the next session will focus exactly on the benefit of carbon ions for treating patients with pancreatic cancer. Thank you very much.
Thank you.
Thank you.